Welcome to the final general session of the conference. It's hard to believe it's already Wednesday. Over the past several days, we've learned a lot about ways that the Aging Network can best meet the needs of our nation's growing aging population, and we're not done yet. This morning, we'll start off with a dynamic discussion on the importance of population health and how the programs you run help to achieve positive health outcomes among different groups of older adults with complex needs. But before we get started, let me begin by acknowledging our good friends at Cigna for their support of this session. Cigna Corporation is a global health services company dedicated to improving the health, well-being, and peace of mind of those they serve. Cigna delivers choice, predictability, affordability, and quality care through integrated capabilities and connecting personal solutions that advance person health. All products and services include an integrated suite of health services such as medical, dental, behavioral health, pharmacy, vision, supplemental benefits, and other related products, including group life, accident, and disability insurance. Cigna maintains sales capability in over 30 countries and jurisdictions and has more than 150 million customers throughout the world. This morning, we are so thrilled to have Carla Vigilante, Director of Community Outreach, Medicaid, and also Karen Donahue, Cigna Medicare National Telesales Manager, and Aletta Davis Clinton, Senior Regional Marketing Manager for Arizona and Texas, with us from Cigna. So for our Cigna folks, please stand. A warm welcome and a warm, heartfelt thank you for your support of N4a in this fantastic session. And now to begin our final general session of the conference. In 2017, N4a's past president, Kathy Bowles, created the Mission Forward Committee to address the changes that need to happen to enhance, strengthen, and position area agencies on aging and Title VI programs for the future. Current N4a president, Deborah Stonewalls, has continued to move this committee forward throughout her presidency. Recognizing that as specialists in home and community-based services that address the social determinants of health, the Aging Network supports population health efforts to serve people most at risk. One of the Mission Forward Committee's main focuses this past year has been on population health and population solutions. So I now want to call to the podium Deb to join us on stage so she can share with you more about the Mission Forward Committee's focus on population health and how your work every day works to improve the population health of your community. Deb?
Thank you, Sandy. Thank you, Sandy, and good morning, everyone. As we close out this year's conference, I hope you have found ways to enjoy New Orleans in the past 5 days, and I hope you've learned a lot. We've had networking, we've had connection, and I trust that all of you have found that as valuable as I have. As Sandy shared, recognizing the critical importance of the Mission Forward Committee, I've continued this critical work throughout the first year of my presidency. This committee has undertaken extensive efforts to develop goals for N4a to pursue that will position AAA's and Title VI programs to continue to grow our service lines, our diversity funding, to strengthen our partnerships with healthcare, and to tackle critical and emerging population health issues. We want to address population health with caregivers, with individuals living with dementia, with people with disabilities of all ages, and those needing advanced care. I'd like to ask the members of the Mission Forward Committee to please stand and be recognized. So where are you guys? Thank you all for your work in helping to move the network forward. Now, we know that health outcomes vary tremendously between diverse racial and ethnic groups, as well as those living with dementia or living in rural areas. And we know how important it is to create and implement programs and services that help, I should have brought some water. Thank you, Sandy. When your lips start sticking to your teeth, it's a problem. In case you didn't know, I'm here to offer you some practical advice. Very down to earth. Sorry, I grew up in Texas, and sometimes, I know, woo! So, as I was saying, we know how important it is to create and implement programs and services that help issues drive poor health among, I'm lost on this, sorry. Whew. I started in the middle. See, we've got this teleprompter in case you didn't know. And I just need to, okay, here it is. Rewind. We know health outcomes vary tremendously between different diverse racial and ethnic groups, as well as those living with dementia or living in rural areas, and how important it is to create and implement programs and services that help issues that drive poor health amongst different populations. Population health involves building and sustaining partnerships among different sectors of the community and using interdisciplinary approaches to achieve positive health outcomes among diverse groups of people. This is certainly something that the Aging Network knows all about. We do this every single day. But as we look to move our mission forward, our collective mission forward, a focus on population health and social determinants of health, along with the increasing complexity of the needs of the nation's aging population, will impact service delivery. It is only fitting that our keynote speaker today is Dr. Alexis Skoufalos. All right, I practiced. Alexis is responsible for facilitating external partnerships and collaborative initiatives for Jefferson College of Population Health as the Associate Dean of Strategic Development. As Executive Director of the college's Center for Population Health Innovation, who knew they had something like that, right? That is very progressive. She leads the team that implements the college's professional development and consulting activities, including expert panel roundtables, specialized training programs, conferences, and symposiums. Alexis also oversees JCPH's external communications, including the college's affiliated peer-reviewed journals and newsletters, website, blog, and social media. In addition to her responsibilities at JCPH, she serves as the co-chair of the steering committee for Jefferson Continuing Professional Development. She is a member of the Enterprise Innovation Evaluation Committee, and she serves on the Academic Advisory Committee for Jefferson's Institute of Emerging Health Professions. Alexis has held leadership roles in multiple stakeholder collaborative projects at the local and national levels that were focused on diabetes prevention, patient engagement, childhood obesity, and issues regarding rural aging and elder abuse. Alexis has had a distinguished career in population health, and we are very, very lucky to have her here with us this morning. Alexis, we welcome you.
Good morning, everyone. I brought my water just in case.
All right.
Thank you. You were a great role model. I appreciate that. So thank you again, Deb, for that very kind introduction and for the invitation to participate in today's program. I really appreciate having the opportunity to talk with you today about population health and how it relates to your work in supporting older adults. Prior to coming to Jefferson in 2005, I spent over a dozen years working in community-based programming to support people of all ages with developmental disabilities. I was responsible for staff development and onboarding training for the whole organization, from our direct support workers and teachers to the frontline supervisors and leadership team. That experience working in community support services gave me a solid foundation to work in population health. By the end of this session, I hope to give you a better idea of the important role you can play in improving overall health and well-being for older Americans. Healthcare professionals can't do this without you. I'd like to begin with a very short video to give you a starting point for today's conversation. It's literally just over 1 minute, and full disclosure, it does have about 10 seconds of promotion for our college. I couldn't edit that out.
How do you keep the world healthy? The possibilities seem innumerable. But when you pinpoint the right data and filter it through the right lens, the best solutions have a way of bubbling up to the surface. That's what population health is all about. Learning to use the tools you have to find the answers you need. As the first of its kind, the College of Population Health at Thomas Jefferson University in Philadelphia teaches future leaders the nuts and bolts of moving and shaking, combining public policy, population data, and clinical expertise with on-the-ground insight and economic analysis to help you find answers that will reinvent the system. Seated in one of the nation's most diverse groups of populations, and at the epicenter of one of healthcare's fastest-growing hubs, students will find opportunity for collaboration and industry partnerships at every turn, on campus or online. Our high-tech, high-touch curriculum is built to help you build bridges between health and healthcare. So, how do you keep the world healthy? You start at Jefferson, then redefine everything.
Yay, okay, got it to work. Let me go back for a second. So as you can see from that, I know it was short, but population health can be kind of complicated. It involves sorting through lots of different information so that you can uncover the best way to meet the needs of a specific group, whether that's a community, a neighborhood, or a group of people with a particular condition. At its core, population health is about taking the time to really look at things from different vantage points. You won't get the same view looking at something through a telescope as you would looking through a microscope, even though you're looking at the same thing. So it's really important to be able to adjust your perspective so that you can figure out the right course of action. At Jefferson, we thought it was important to create a college and formal programs that would help to prepare the workforce for this new challenge. This is very complicated looking, but 10 years ago, we started to prepare professionals to work in the emerging discipline of population health. That meant we had to create a lot of the curriculum from scratch. So that's been an interesting endeavor over the last 10 years. We are the newest college at Thomas Jefferson University in Philadelphia, which was home to one of the nation's first medical colleges in 1824. I honestly think we spent the first 5 years explaining what population health is. A lot of people confuse population health with public health. And while they're related, they are different disciplines. Public health focuses on prevention and health promotion, things like clean water, vaccines, exercise, using seat belts and bike helmets, but it stops there. Population health builds on the foundation of that public health work, but it goes a step further, working to connect health and healthcare delivery. It takes a more holistic approach, looking at what we need to do inside and outside the delivery system to help people to get and stay healthy and to take better care of them when they do get sick. We work to identify and understand the health impact of social and environmental factors, while also looking for ways to make healthcare delivery safer, better, more affordable, and accessible. Our college includes several components in addition to the formal academic program, and you notice that on the blue side, that's the Center for Population Health Innovation. We incorporate fellowships, community-based research, regular continuing education, conferences, and publications in an effort to try multiple modes to address the needs of all of the stakeholders in the health ecosystem. Healthcare providers need to learn to work with the other stakeholders in the system if we're going to be successful in improving population health. Cooperation, collaboration, and coordination are the ways to make the best use of increasingly scarce financial resources. We really need to get smart about the way we work. It's important for delivery systems to establish good working relationships with community nonprofit and service organizations, faith-based organizations, social service providers, school systems, and government at all levels. Our Center for Population Health Innovation focuses on outreach and technical assistance. We strive to equip the range of stakeholders with the tools they need to collaborate to improve population health. We have at our disposal a core group of faculty, staff, and fellows on site in Philadelphia, as well as dozens of adjuncts who teach online across the country. And they're able and available to provide training and technical assistance with implementation and evaluation at the local level. While the issues are the same, specific challenges can be very different based on the way needs and conditions present on the ground in local communities. Population health is very much like real estate in that respect. It's all about location. That's why we worked hard to establish 2 freestanding community-based centers to support local population health research, each of them associated with a local hospital system. The one on the left, Mainline Health Center for Population Health Research, sits on the border between one of Philadelphia's poorest urban neighborhoods and one of the nation's highest income suburbs. And they have to work to figure out how to meet the needs of both of those populations. The other is in Johnstown, Pennsylvania, situated midway between Harrisburg, the state capital, and Pittsburgh. We think their work will help us to understand how best to customize interventions to address health issues based on local social variables, so we can help to create models of practice that can be exported elsewhere. All of this background was meant to tee up the main conversation regarding the social determinants of health and their profound connection to health outcomes. This graphic, I hope, helps to illustrate a little the relationship of various social factors that, taken individually or in combination, affect a person's or community's health status. Health behaviors are critically important regardless of your age. Whether you smoke, what kind of a diet you eat, how much alcohol you use, or other substances. But other factors, largely outside of your direct control, also make a difference. Things like having a safe, secure place to live. Your level of education determines the type of job you can get and your degree of economic security. This, in turn, affects your access to healthcare services and insurance to pay for those things that you need. Perhaps most important for older adults is having a strong social network. I don't have to tell you, by nature, humans are social animals, and we thrive when we have a good supportive network of friends and family. For older adults in particular, social factors significantly impact their health and their experience of aging, especially in terms of their ability to live independently and age in place for as long as possible. Poverty amplifies the negative impact of factors such as food and housing, transportation, access to healthcare services and medication, and social isolation and loneliness. Let's take a moment to consider the added weight of some of these factors when viewed in the context of aging. Again, health is definitely affected by having a roof over your head and a place to call home. But unfortunately, the rate of homelessness among people over the age of 60 is on the rise. How good can your health be if you're living in your car or on the street, especially if you have a chronic condition or mobility issues? How good can your health be without the social connectedness of friends or family? How good can your health be without regular meals or enough money to pay for prescriptions, pay the rent, and keep the heat and lights on? Taken collectively, these factors heighten the risk of cognitive decline, dementia, depression, and overall poor health outcomes. Social isolation is perhaps the most debilitating risk factor of all. Social isolation and loneliness have been shown to pose significant risks to health and well-being for people of any age. According to recent studies, social isolation is associated with a 29% increased risk of mortality and poses a greater cardiovascular risk than obesity, high blood pressure, and high cholesterol. It actually poses the same health risk as smoking 15 cigarettes a day. And as we age, we become even more vulnerable to the negative effects of social isolation. Just think for a moment how much smaller a person's social network becomes after they retire. The lack of a routine, the schedule, even minor social interactions with people is enough to throw someone really off. By their mid-60s, many people will have one or more chronic health conditions, and a person may find it more difficult to get around and need to depend on others for help with errands, shopping, or getting to doctor's visits. Almost half of women 75 or older live alone, and living alone has a profound effect on mental state. If a person's spouse or partner has died or left the relationship, their risk of social isolation is greater. And serving as a caregiver for an ill or impaired spouse or partner can contribute even more to social isolation, increased stress, and risk of depression. Socially isolated older adults cost Medicare an additional $6.5 billion annually because of its association with functional decline and the risk for developing dementia. And both the risk and impact of social isolation are increased for people living in rural areas. Although rural communities tend to be very close-knit, the physical distance between people can be difficult to overcome. Incomes in rural communities tend to be lower because there are fewer job opportunities. That, in turn, causes out-migration of young people, so you have fewer and fewer people around to provide that social connectedness and other supports. And with a smaller tax base to draw from, there are fewer community resources and activities even available. The lack of public transportation makes it difficult to access healthcare providers, and generally there are fewer of them available. And we've all heard the stories about rural hospitals closing at an alarming rate. None of the information I've given in the last few slides is news to most of you, and I'm sorry it is a little depressing, but the good news is the environment has changed, particularly in terms of payment and its relationship to accountability for outcomes. And that's very good news for the families and individuals your programs are serving. You have a key role to play in population health, one that your colleagues in healthcare service delivery are finally beginning to recognize and understand. And if you position your organization well and can demonstrate the effectiveness of your programming, you will be able to sustain and possibly even expand your footprint and impact. Good health is an asset and a desired state of being that requires a little investment. And the way our system is currently structured, America spends far too much on paying to fix health once it's actually broken, and not enough on what helps to keep people healthy. The factors that influence a person's health occur largely outside the healthcare delivery system, and spending on services that support health actually saves the system money and improves the quality of life. Under new bundled payment paradigms, the structure is shifting away from fee-for-service to more value-based payment that allows for flexibility in procuring supportive services that help to keep people out of the hospital and the emergency room. So now that health systems are being paid based on the quality of the outcomes they achieve, they are starting to work to collaborate with organizations and agencies that can help them earn their quality incentive bonuses, because they will make out better that way. Here are some examples of successful collaborations. Area Agency on Aging's involvement in a broad variety of cross-sector collaborations with healthcare and social service organizations is associated with reduced hospital readmission rates. AAAs that work directly with individuals in their homes and communities have really good experience addressing issues that are beyond the traditional reach of clinicians. Community-based organizations can identify and address risk factors that can have an impact on health and healthcare spending. Some examples include poor self-care skills, identifying environmental hazards or the need for social supports or protection from abuse, mental health challenges, or difficulty with medication management. These are lots of areas where you guys can be really, really helpful. Community-based organizations that are successful in this regard most frequently will contract with Medicaid managed care organizations, hospital systems, VA medical centers, and Medicare Medicaid duals plans. The really good news is that we have reached an inflection point where the moral imperative to do the right thing is finally able to be connected to a financial incentive that will make it happen. AAAs can improve their relevance, sustainability, and impact by learning how to demonstrate and quantify the value they bring to local payer groups. When you can articulate and document the impact of your programs, you're on your way to becoming a provider of choice and an integral part of a preferred network of services. Learn to become a great storyteller. Bring your evidence, and you will be able to make a world of difference for those you serve. I'm excited to get to the next segment of our session because we're going to hear from some of your colleagues who've been successful in implementing some terrific programs. And hopefully, they're going to serve as a source of inspiration to you or help you to provide a roadmap to chart your organization's journey to population health. Thank you. To bring the issue of population health home, I'm now going to be joined by a panel of 5 of your Aging Network colleagues who are working to address population health within their communities. The panel and I are going to discuss ways agencies can work to address the complex needs of older adults living in poverty, living with dementia, living in rural and remote frontier areas, those from diverse cultures, or those tackling advanced illness and end-of-life issues, as well as those dealing with overcoming the devastation of natural and man-made disasters, because goodness knows with the weather we've been having, or there's going to be more of that. I'd like to welcome the panel to join me on the stage as I call their names. First, we have Dawn Simonson, the Executive Director of the Metropolitan Area Agencies on Aging in Arden Hills, Minnesota, who will discuss dementia. Next, we have Donna Harvey, CEO of the Northeast Iowa Agency on Aging, Waterloo, Iowa, who will highlight rural aging. Connie Benton Wolfe, President and CEO of Aging and In-Home Services of Northeast Indiana in Fort Wayne. Connie will talk about advanced illness and end-of-life issues. Shireen McSpadden, Executive Director of the San Francisco Department of Aging and Adult Services, will discuss diversity. And our hometown hero and host, Howard Rodgers, the Director of the New Orleans Council on Aging in New Orleans, will address disaster recovery. Well, before we actually get into the panel questions, each panelist is going to have 5 minutes to discuss how his or her agency is working to address a specific topic area. So Dawn, I'm going to ask you to kick it off to talk about the needs of older adults living with dementia.
Great, thanks Alexis. Good morning everybody, so great to be here today on the last day of just our fabulous conference. Sandy and Alexis asked me to speak about dementia, and I think the perspective that I share today is not only the perspective of the AAA in Minneapolis and St. Paul, but certainly one of all of you. And as we've begun to really understand Alzheimer's and other dementias, I think we do think of it as a population health crisis for families in our country. The numbers of people living with Alzheimer's today, almost 6 million, and we know that the care partners of our family members affected number almost 16 million people, and that will just grow and grow over the next decades. Well, most people pin their hopes on a cure, right? We all hope there's a cure for dementia or something that will slow progression. Really, our job as area agencies on aging today is to help people with dementia live their best lives. I think that's such a reframing statement that is so important, and we know that supporting care partners is really essential. So I think that we all know, and perhaps we need to, again, think about reframing. We've talked a lot about reframing in our conference this year. AAAs already are part of the solution, and we bring value in 4 ways. I think first, we know there's a growing interest in the brain health connection, right? So healthy brains derive in part from healthy bodies. And the core AAA services that we provide, meals, transportation, we're already part of the solution, and thinking about reframing and packaging those services for purchase by healthcare is something that we're all really passionate about working so hard to do. So as we think about, what does that mean? How do we get a little more specific? We know that meals, right, nutrition is very important for somebody's health. We know that rides to the doctor for treatment, for preventive services, to control conditions such as high blood pressure and diabetes, 2 risk factors for dementia, are really critical. So not only do we provide meals, do we provide transportation, but we're helping combat high blood pressure, diabetes, and other conditions that lead to dementia. So the second component where we're all just shining, I think, is our community engagement work, whether we're working to develop age-friendly communities or more specifically dementia-friendly communities. We're all helping to combat isolation. All of the work we do to reduce the stigma of dementia helps support people, again, to participate in the community and really provide bridges and ramps to community participation. So as we think about programs like Dementia Friends, and I know it's growing in amazing leaps and bounds across the country, across generations, across cultures, we're doing amazing work to reduce isolation. I think third, we have a role in preventing new chronic conditions, as well as preventing older adults from developing or exacerbating an existing chronic condition. 90-some% of us are really focusing on evidence-based chronic disease management and fitness programs. And if we really double down on those efforts and work to build scale in community offerings around evidence-based health promotion programs, we can make a significant impact, I think an impact at the population health level. So we've been learning too at the conference that health plans as payers are interested in supporting these classes for their members, that this is true in Minnesota, where we have interest in health plans paying for members who are dually eligible, those who have enrolled in a Medicare supplement, and certainly those enrolled in Medicare Advantage plans. Again, healthy body, healthy brain. Fourth and finally, AAA's support frontline unpaid caregivers of people living with dementia. You all know the value of respite, support groups, coaching, and consultation. Being a dementia caregiver really does lead to a greater risk of that caregiver, right, acquiring a chronic condition or worsening an existing chronic condition. And we have answers. We are all deploying evidence-based caregiver support resources, programs like REACH that are tailored to care partners of people with dementia. And these programs then can help break that pattern of developing chronic disease or of moving to more harmful alcohol and substance abuse. So we know how essential caregivers are. The supports we all offer are just very critical to the work that they do to help their care partner, their care recipient who has dementia. But we also need to really think about preventing the development of dementia among caregivers. So helping caregivers stay healthy, I think, is really a way that we can have a multiplier effect at work here and help to reduce the incidence of dementia in the future. Thank you. My comments.
That's great, thank you. I really love the idea of that multiplier effect, because all I could think of when I was hearing you speak is you're not just serving the person with dementia, you're saving the system money and by protecting the caregiver and the other people that they touch in their lives.
That's right. Thank you.
Really great. Thank you. Donna.
Well, I'm going to talk about something I'm very passionate about, and that's rural. I'm fortunate that I grew up on a farm, so I think I get the concept of rural. I live in Iowa. I think everybody...
I think you get that.
I think I get that. I live in Iowa, so again, I think everybody who has ever not been to Iowa would think we're rural, and I would agree with that. I used to say, yes, we have corn and we do have pigs. That's our... but we have luxury accommodations.
We have a tall building. You do.
We have luxury accommodations for pigs these days in the confinement. But honestly, Dennis Dudley, who is now retired regional director for the Administration on Aging and Administration for Community Living, I think was one of the early champions of rural, along with Pam Mature, who is recently deceased, from Ohio. And they probably opened my eyes more than anybody. So I was asked to be on the National Committee for Rural Health and Human Services. As I traveled throughout the country to look at rural, I think it made me pause about how difficult this is, and it's not your address. It's not that you live on a farm. The first time that the committee said, we're going to go to California, I thought, rural in California? Are you kidding me? But once we went to the very northern part, it is very rural. They have challenges that I would never have with transportation in Iowa. So it's a challenge to all of you to really open your eyes as we discuss rural. I went to a conference in Atlanta, and we were to introduce ourselves. Are you urban or rural? Well, I'm very proud. I'm from Waterloo. It has over 50,000. We're urban. But Atlanta said, we just went over 3 million, and then I went, oh, the whole state of Iowa is rural. So I think...
Well, even the feds don't know how to define it. It's all based on how close you are to concentrations of people.
There are at least 30 definitions of rural. So my challenge to all of you and to all of us is, as we begin to work at partnerships, we need to make sure we're defining rural in the same context that the potential partner and funder is defining rural, and that we can adapt quickly, because I think that's what this network is best at doing. My staff who are here and other Iowans said their brains are busting open after this conference. So I think congratulations to all the presenters that have now busted brains, but all of us who have many, many opportunities and challenges ahead of us. So when I was asked to talk about rural and what we're looking at, what I would say is we're looking at redefining who we are. We've been in business a very long time. We've been doing what we're doing, but defining it differently is becoming more and more important and critical. Yesterday, there was a speaker who said, we are the secret sauce, and quit giving it away for free. And at our organization, that's something we are working hard at doing, because we've always been the collaborator to go to the table that said we're here to help. We can no longer afford to do that, and I think we demean ourselves whenever we do that. So, and some of you came to the workshop, and I appreciate that. We are now no longer talking about contribution only. We're having discussions with everybody about personal financial participation in our programs, that we are a valuable service delivery no matter what you're receiving from us, and it's important investment from our consumers and anybody else. So I think, and that's something you can do regardless of what your address is or how large your organization is. We're looking at the food desert issue. In Iowa, between, I think I looked up 1996 to 2000, we lost 50% of our local grocery stores. That has been a huge, huge impact to rural Iowa. And so we're looking at what does that mean and how do we redefine our meal program, our nutrition program, and how can we find the gray? If you didn't hear the testimony from Larry, who's the director of Southern Maine Area Agency on Aging, and I say that because you need to go to their website to look at their nutrition approaches, he's busting their doors open. They're looking at vouchers, they're looking at brown bags, they're looking at delivering frozen meals, but recruiting buddies to come in and heat them up. And then what I think we don't sell enough is that safety check. When we deliver that meal to the door through volunteers, we are ensuring that individual is safe. And I think in the rural area, that becomes even more critical because while they are connected in a weird sort of way, I think it's getting worse. And so that social isolation piece, when I think about how I communicate with my mother, embarrassingly, I do most of it through texting. And she texts back. But we have a weekly set-aside time where we have a phone call. She lives 120 miles from me. I don't know that a lot of people do that. And when I think about the last time I had a face-to-face conversation with my grandchildren, it's been a long time. So I think it's a challenge to all of us to think about how is a communication occurring between caregivers and their elder loved ones, particularly in rural areas, because when you get to very far northeast Iowa, we cannot get a cell service that covers our entire 18-county service area. So when I hear about the advancement of technology to keep people in their home, I kind of go, yeah, well, that's great. Not going to help it on the farm, nor is it affordable. I don't know about the rest of you, but I look at my cable bill, I look at my internet bill, I look at my cell phone, and I say to my husband, we spend $485 a month to stay connected. No older person can afford to do that. So what are we going to do to address that need? Then I'm going to talk quickly about congregate meal programs. In our area, they are going away. We're not finding folks coming in at all. And so we're looking at rebranding, reapproaching to what we're trying to call natural occurring senior locations. We have Casey's, and I know there are different parts of the country. Quick Start, Quick Trip. They're capturing the loss of grocery stores and the need for social gathering places. They are now putting tables and chairs. Well, we're starting to approach them. Can we become what we're calling a gathering place? So we're trying to take senior center out of our name and call it a gathering place so that it really starts to feel comfortable to stop by, have a cup of coffee. If you want to eat a donut, have a donut. We're not going to fight that fight, but we're going to have nutrition education once a month in that location. So again, I think, let's get our thinking cap on and think about where we might go differently. The other piece that I think I want to talk quickly about is transportation. Scratch my head. Virginia Dyes is the queen of transportation collaboration. But boy, that is an ongoing issue. You know, we've loved having so much Uber and Lyft and taxi cabs. I'm going to go home where we had somebody come from Ohio visit our agency, and he called me from the hotel saying, I'm sorry, but can you pick me up? You have one Uber driver and he's sick today.
That happened to me in Maine.
Yeah.
I couldn't get to where I was supposed to go.
And that's in the urban area of Iowa. So.
Yep.
So we have a long way to go to think about
Tractors.
how
Maybe
transportation
Uber on a tractor. That might work.
A tractor with wagons. I like that. But yeah, you never know. It might work. But the last thing I want to leave with this piece is that there's a term that one of my staff person has posted on her wall, and it's mudita. Never heard of it. No. So I looked it up, and I'm going to read it so I don't mess it up. Mudita is the pleasure of finding joy in the happiness and success of others. And I think that really embraces what this network is and has been and continue to be, that when we work together, it's an opportunity to really be able to celebrate mudita. And that we need to think of that as we move forward, particularly in the rural area, about it doesn't have to be us, it has to be us doing it together.
That was great. Thank you. Thank you. All righty, next we're going to hear from Connie.
Well, my task today is to talk about serious illness, which is kind of daunting after I'm following Donna Harvey talking about the fun life in Iowa. Okay.
Connie's
I happen
from
to grow
Iowa.
up and have lived a big portion of my life. But I do want to address the notion of area agencies on aging and our work with individuals who have serious or advanced illness, because that's something that has been a growing part of the work that we're doing in my agency in Northeast Indiana. About 5 years ago, we had the good fortune of being part of a research project, a PCORI grant, that Dr. Lee Lindquist from Northwestern University in Chicago was doing. And she was looking for a rural part of the world where she could actually do some focus groups. So she happened to link up with us because we had a real interest in participating in research. We had somebody on staff who knew how to do it and who was eager to group the folks together that she might need to talk to. And so she came in and did a lot of work in our region. And her project, her PCORI project, was all about gathering information about lifespan planning. And her theory was that if we take a look at serious illness and plot it, we can see what the home and community-based services needs of those individuals with the serious illness might be. And we can better plan for that. And if we came up with a tool to help individuals and their families do that, we would all be better prepared along those lines. And as she became really kind of a part of our agency for a little while, she really informed the work that we did with a number of our clients. Her assumption coming into working with us 5 years ago was that, of course, we were tuned into the diagnosis of the clients we were working with, because she came at this from a clinical perspective. At that point in time, we actually weren't all that tuned into the diagnosis of the individual we were working with. It was kind of secondary. It wasn't our thing. We did the social stuff. And so in our own minds, we kept it very isolated over here as well, or segregated from the clinical side. When she came in and started asking us questions, we just started looking at each other going, of course, it makes perfect sense for us to be tuning into that and to begin to integrate into the whole process of our interventions how we work more successfully and effectively with these clients who, in fact, have a serious illness that has a trajectory that we can map. So thank goodness for that intervention, because we were able to really then step back and take a look at all of the work that we do, and it really was part of what drove our agency forward in terms of this whole realm of viewing ourselves as part of community integrated healthcare. We really have redefined ourselves as a community-based health organization, and dealing with patients who have advanced illness, we've recognized now is a major part of what we want to do. That meant a lot of things in terms of rethinking our work. It meant that we had to take a look at the data we were collecting, basic questions that we were asking as people were coming in through our Aging and Disability Resource Center, as they entered into our case management programs. We wanted to be able to collect that data and make sure that it was a part of the ongoing charting of what we do in terms of our work. We needed to do a lot of education with our professional staff and our paraprofessional staff related to how this might change how we interact with an individual coming in. We went through the process of NCQA accreditation because we felt it was very important that we use that as our guide because of the recognition that it gets on the medical side of things, and also because it made us better at what we do in terms of working with the individual in their individual circumstance. So those were all really good things. And we began to modify the way we did our interventions with our clients. We really did alter the questions that we asked and the data that we collected. And the other piece of it was how we create feedback loops into the other medical providers that individual is dealing with. Because somebody who's coming into our system who is categorized as an individual with advanced or serious illness, and it is a huge part of the population that we are all serving. When you stop and think about it, this is one of those aha, no-brainer kind of approaches. And I know later on, I believe we have somebody from, I think Andrew MacPherson from C-TAC is going to be speaking to our group about the work that they're doing, and that's the Coalition for Transforming Advanced Illness that has a wonderful partnership with n4a, and under Sandy's leadership has really kind of moved our presence in that world forward. But as we, as AAA, start thinking about our role with these individuals, there is such an important piece of the work that we do for them that it will make a huge difference. About 3 weeks ago, a friend of mine, a personal friend of mine, called me. She's actually from Michigan, but her sister happened to live in our region of the world, and her sister had received what was a devastating diagnosis for her. So she was on the serious advanced illness trajectory. And my friend Deb kept saying, will you go see her? Will you go see her? And I'm going, I'd be happy to go see her, but you need to understand, I don't know anything, okay? I am happy to go and be supportive. But you don't want me being the one, okay, to help her with her planning, because, unless it's budgets, policy, or an HR issue, I'm pretty, not that helpful in the field. So, but I am, I'm somebody that she had known. And so I decided I was going to tag along with our case manager that was going out to do the assessment, the initial assessment, and begin the process of working with my friend's sister and her family. And it was probably the most important thing I've done with my time lately, and I don't do nearly enough of this, but I sat there and I listened and I watched the eyes of this individual and her husband, who knew that they had a huge challenge in front of them. And I watched my masterful staff sit there and reassure them that we were going to become a part of this journey with them. And it was probably, it still gives me goosebumps because it reminded me why we do this work. It absolutely, you could see the peace that started to come over their face because they were so overwhelmed by their diagnosis and trying to deal with the medical establishment, which was doing what it needed to do for them, but is so overwhelming when you're coming into it with this serious illness diagnosis. And we were the familiar. We were talking about community. We were talking about bringing support in that they could relate to. And they were reassured that they wouldn't be left alone to figure all this out. We talked with them about building their own care team, the importance of doing that, and that we would be right there with them to help them do that. And it was just a tremendous opportunity for me to witness, again, the importance of the work that we all do in the field with folks. Some of what we're talking about, a lot of what we're talking about with population health is a reframing of the work that we have done for years, that we are experts at. But if we're smart, we're going to reframe it in a way that positions us to be a part of the healthcare continuum, which is now defining itself in a more broad sense. And so working with advanced care and folks with serious illness is what you're all doing anyway. So let's just think about how we do that better. We find for the patients that we're working with that we do a lot of coaching on dealing with healthcare systems and being your own healthcare advocate. For a generation of folks that have maybe always sort of taken that word of the medical establishment as gospel, being enlightened that you can actually be the director of your own care is a hugely important piece of this. Because there are a lot of frequent hospitalizations for these patients, we've layered in additional care transitions work that we do with them, and we keep a very close tab on them. We're fortunate because our technology allows us to get pinged when somebody goes into the hospital who's on our case management load, and that makes a huge difference because we can immediately then move into action to try to help them as they transition back home. We've decided in our neck of the woods that we wanted to develop a PACE program, again to serve those very frail, complex patients who were dealing, many of them with advanced or serious illness. So we took the lead as an agency and moved forward with an application. And God willing, we will be opening a PACE program in the spring of 2020. Great. We're starting demo this week. So it started happening while I was gone. So that was kind of exciting. So all of those things are an important part of it. And the other thing that we've layered into the work that we're doing is making sure that our entire staff is trained on advanced care planning and really integrated that language, that work, making sure our clients are focused in those directions in terms of knowing what documents they need to have, understanding that it's all about their direction at that stage in their life in particular, but that they have to take steps in order to protect the fact that they as a patient can have the care that they want. So we've built all of that back seriously into our interventions. And as an area agency, we've really taken the lead statewide in helping that movement with advanced care planning go forward. We're working very closely with the Indiana Elder Law Association. So much of the work that we're doing is informed by that early recognition that seriously ill patients and advanced illness patients are a big part of the client population that we serve.
Thank you so much, Connie. I mean, honestly, America is the only country that treats death as though it were an option. All of us at some point are going to, if we don't have that lovely experience of just passing away quietly in our sleep, we're going to probably likely have to deal with some sort of, terminal illness or something that's progressive. And honestly, the biggest service you can provide is taking away that fear of the unknown and empowering people to be able to make those decisions and to think about it early, not while they're in decline or in an urgent situation, so that they can figure out what it is they want. That provides everyone a better experience. It lowers utilization, which we know is crazy at the last 6 months of life. And for what? You're delaying the inevitable and torturing the person, typically. So thank you so much. Shireen.
So I think one of the things that we need to think about when we think about population health and we think about true population health is thinking about how to be experts at serving diverse populations. And we all know that across the country, as the population ages, it is also diversifying. And I get to talk about San Francisco today because that's where I'm from, and we have a very diverse population there. And Donna, we also have pigs, but they're the little pot-bellied ones that live in people's houses and walk on leashes. So we're different that way. But
see, again, it all depends on how you're looking at it.
Exactly. So San Francisco is incredibly diverse, and the older population has diversified a lot. 20 years ago, our older population was predominantly white, or at least that was the majority. And now we have, I think 42% of our population is Asian Pacific Islander. Over 50% of our population in San Francisco has a primary language other than English. And so, that is challenging for us. And I think the thing that we can do as AAAs is really get good at serving different populations. And in order to do that, we have to understand who those populations are and really use our data. One of the things that we've done in San Francisco is we did an equity analysis to really look at who's using our services and comparing that against our overall population so that we can say, hey, where are we doing a really good job and where are we not doing as good a job? Are we serving the Latino population as well as we should be given the numbers of Latinos in San Francisco? Are we doing as good a job at serving Asian Pacific Islanders and the various populations within the Asian Pacific Islander population, because we know there are many different cultures within that. How are we doing at that? And in doing that, that really gave us good data to figure out, hey, how do we make sure that we're reaching out to populations that we should be reaching out to, and how do we measure our own success at serving people? So we know that all of the AAA services are super valuable, but people sometimes need to get those services delivered in different ways. And, they need to be delivered by people who, I think we all know that people like to receive services from people who look like them, speak their languages, and all of those things, and how important that is. And, when we're thinking about things like about social isolation and hunger And the things that we address all the time as AAAs, we really have to take into account, are people going to feel comfortable receiving services from us, and how are we addressing the diverse needs that we have in our communities? I think, and the other thing that we're constantly thinking about in San Francisco is we also are serving more and more people who live in poverty. And I think as the population across the country, the population of older adults grows, and we know that the basic protections that people had, the pensions and Social Security and things that used to be enough are no longer enough, we also have to think about, how do we prioritize services for people, and what is most important? When I was in my 20s, I think I was a case manager, and I had a client who called me and said, could you bring me a food box? I had to use my last few dollars to pay for my cable bill. And at the time I thought, cable? Are you kidding me? Because I didn't have enough experience to understand what she was saying is that she was isolated and she really needed that television because that was her window to the outside world. And that was more important, as you stated earlier, that was more important to her than food. And also she knew that I could bring her a food box. And I think, having real conversations with people, asking them first, putting people first, and realizing that one answer from somebody who is from one culture may be very different from what somebody else's needs. And think, we've done a lot of work in the past few years doing community needs assessment and really asking communities what they need and why they need it, and trying to develop programs that really meet those needs. And they may look very different across cultures. And so to the extent that we can be really good at this, and I think a lot of us are getting there, that's something that we can share. And it's also something that is very valuable monetarily to people who don't have the time to figure that out and create those kinds of programs that are nuanced enough to really serve people the way they should be served.
Thank you. I'm just struck to hear you talk because I'm in Philadelphia, and I think a lot of the issues that we struggle with in Philadelphia are very similar. We have a very high degree of people living in poverty, many, many different cultures. In addition to the Asian Pacific Islander, we've got people from African countries, Caribbean countries, Eastern European, and many of them are not English speaking. One of the other populations I was hoping you might touch on, our public health students work at a community-based organization called Philly Fight, and it serves the LGBTQ community and all of that. Understanding now that more people are out, more people are transitioning, how do you see that changing the way you're going to be providing services? Because you may have many, but people who have not come out, based on culture and all of that.
Well, so we've done a lot of work in San Francisco to train our staff and train our community providers on asking questions about sexual orientation and gender identity, and really being sensitive to people's experiences and things like that. I mean, we have a lot of services that we provide specifically for LGBTQ people in San Francisco. We estimate that about 12% of the older adult population identifies as LGBTQ. That said, we're still working on really making sure that our more mainstream programs are sensitive and able to serve that population. And we know from our equity analysis that we just did that we're actually not doing as good a job with the population in our mainstream services as we had hoped. And so we're doing a lot of work with our providers to try to figure out what the problems are, actually ask the LGBTQ populations and the subpopulations within that kind of big group, what would it take for them to use our services, and how can we be better?
Yeah, it's difficult, and it's going to be changing. Super. Yes. Thank you so much. Howard, you're batting cleanup.
How about that?
How you doing?
I'm doing fine. How's everybody here doing? How's that waistline? I'm sitting here listening about potbelly pigs and pigs, and I'm saying, well, we could just get one and throw it on the pit and have a cochon de lait and have a pig roast right now. Throw in some crawfish and pull out some beer, and hey, we'll just have another party.
Throw on the grill.
Unfortunately, on August 25th, 2005, growing up, you would always look at, talk about December 7th, 1941, a day that would live in infamy. And has, President Roosevelt addressing the nation. Well, August 25th, 2005 is a day that will always live in the history of the city of New Orleans. That's the day the levees broke. You can say that it was, number one, it was a natural disaster, Hurricane Katrina, but it was also a man-made disaster. And that was because the federal levees, the levees that surround the city of New Orleans, were not designed to take a tidal surge coming out of Lake Pontchartrain into the outflow canals. And what succeeded was the canals broke and the city flooded. It's interesting that we're here at the Hilton Hotel. 3 blocks down is the New Orleans Convention Center. And if you remember looking at CNN and MSNBC and Fox and all of the major stations, and you saw the devastation and the suffering 3 blocks from here, today you walk down, it's not in your mindset. People really don't think about it. But the thing in terms of disaster preparedness and preparing for a disaster, it can happen at any time. Mm-hmm. 2 weeks ago, we had a tropical storm. And unfortunately, New Orleans suffers from PTSD. In fact, some of you suffered from PTSD yesterday because you saw the rain coming down, and a lot of you told me, I can't get out. What's going on? This is going to flood. No. But, it's kind of devastating when you think about what we went through, and especially what my agency and what my staff went through. Just imagine this. Number one, your city is gone. Number two, the population that you serve is like, the Bible. We were spreading. We were gone. It was like the Tower of Babel. Everybody was everywhere. And then the last part of that is the personal side of it. What about your staff? Mm-hmm. So the task that my staff, and especially, I'd love to give shout outs to my assistant director. He and I took on this task, and we utilized the Marines' motto: we adopt and we overcame. Because we had 3 things to do. Number one, we had to reestablish our agency, and thanks to the Governor's Office of Elderly Affairs, and especially at the time the Administration on Aging and Josefina Carbonell and all of her staff who came down and gave us some assistance. We were able to reestablish our office in Baton Rouge in the East Baton Rouge Council on Aging for 4 months until we were able to come back here and try to find a place where we could establish our operations, and also at that same time mentor and counsel to not only those seniors who you knew who were contacting you trying to find out what was going on, but also to talking and helping out your staff because they had to rebuild their lives too. And added all of that myself, because I was homeless for 6 months. Yeah. We stayed in first we stayed in the executive director of the East Baton Rouge Council on Aging. Thanks to him, he allowed us to utilize his father's house that was for sale. So we used that, and when we went to go clean it up one time, when he first gave us the keys, we decided to call that the Roach Motel. All right, but I mean, it was just our thing of keeping some humor in the situation because of the task that we had to do in terms of bringing services back to the city. So it's been 14 years. We still see some of the scars of Katrina, but we have been able, with the cities, first with FEMA's help, then with the city's help, to establish a mechanism now in our city, in our state, in case of another natural disaster or hopefully no more a man-made disaster. And so one of the things that I like for our colleagues here to take away from here today is that in the event of a natural disaster, you also have to remember that trying to get the services back to those individuals that we serve, number one, do they really need what we have right now? Do we have to change what we're giving to them? Well, I say that is this. One of the things that we found out after the storm, there were 1,500 individuals who perished in Katrina. 70% of those were over the age of 60. 70% over the age of 60. When we did some research, we found out that some of those individuals decided to stay because they didn't want to lose their possessions.
Yeah.
We also found out that some of them stayed because, and you know, y'all gonna laugh on this one of our senior centers had a party 2 nights before. And so they didn't care about the storm because they had been through Betsy. That was in 1965. That was, and you know, and if you survived Betsy, then you could survive Katrina, but nobody thought that Katrina would flood at least 70% of the city. So as we went forward, one of the things that we did do is we established a mental health program. But then when we established that mental health program, we found that people didn't want to open up to us. So we changed it to healthy aging. And then they started to talk about their problems. They talked about their struggles, and we were able to help them. One of the things that you mentioned earlier is to be able to tell a story. You know, and these are some of my stories that I'll never forget. It's one that always gets to me. Prior to the storm, we have an organization called the Elder Action Coalition. And every year, and it's comprised of individuals from various services or related services to the elderly community here in the city of New Orleans. And so that particular year, we started to talk about hurricane preparedness. And in the process, we found out that the city of New Orleans did not have a comprehensive hurricane preparedness plan. And at this particular meeting, which was our July meeting, we had the individuals from the city there, and we were talking to them, and we said, well, where's the plan? And the guy who was in charge said, well, we have a plan. And I distinctly remember my community, the director of community services says, you don't have a plan? Why do you want to lie to us like this? There is no plan. And so a week after that, the mayor, Ray Nagin at the time, he was kicking off his reelection campaign. And so I was invited to go to his reelection campaign. As I walked up to him and I talked to him, I said, well, Mayor Nagin, I said, we've uncovered that there are 30,000 individuals in the city of New Orleans who do not have transportation. We have to do something about this. And a number of those, out of that 30,000, at least a good 20,000 are seniors. And I will never forget this because this is something that always sticks with me. When I said, well, what do you plan to do? What do you think about? What can we do? And his reply to me was, well, there's always the Superdome. And if you remember,
yeah, that's where everybody went.
The scenes coming out of the Superdome. And I was in Shreveport, and I remember him standing outside of the Superdome with a towel wiping his head, just standing there looking at what was happening. Well, fortunately, we're not in that position today. Today, with the assistance of FEMA and the city has developed what we have is a 311 call system. So we have a system that assists those individuals who have special needs. I have a cable television program that runs once a month. Well, actually it runs every week, but once a month we change. And for these last 3, and I dedicate June, July, and August to hurricane preparedness. So we hear from, not only from individuals from the city, we hear from the local power company, and we also, and the last segment we taped was with the local transportation. So between those 3 organizations, we have been able to develop a comprehensive plan in case there is another storm. And you know, one of the things that we do a lot here in New Orleans is that we pray, all right? And before I have a parting gift for all of you, and if I could give you that gift right now, and that is this. This is a prayer for the elderly and for those who care for them. Gracious God, we ask you to bless especially your children who have grown old when they can no longer care for themselves. Send them loving caretakers who appreciate their wisdom and the richness of their experience. Send your angels to keep them safe as long as they live and to lead them home to you when their work is done. Bless the families of the elderly with insight and good judgment. Help us to remember we are doing your work. Amen.
Wow. That's really powerful. Yeah, they gave me this list of questions to ask, and I think we're just gonna, we're good. No, actually, we're good, and I think we're right about at time. So I'm going to thank you again, all of you, for your wonderful insights and your wonderful remarks. I'm going to call Sandy up here to help us take some questions from the audience.
Thank you. Well, you know, I would have to say what an amazing panel. And Howard, what an incredible inspiration for all of us as we go forth from here. But with this panel and the discussion about population health and how important it is as we look at the diversity of the populations that we all serve, but also throughout this conference we've talked about the importance of building that bridge between the work that we do in aging and social services and the work that we do in healthcare. And I think this discussion around defining the work that you do in that population health arena is going to be critical to that. So what I'd like to do is to open it up to questions for both Alexis and also our panel that you might have about population health and how we can, as area agencies on aging and Title VI programs, really capitalize on the work that you do under the population health umbrella. So we have some mic runners in the audience with microphones that'll be brought to you. So please raise your hand high if you have a question for Alexis or the audience. There.
Good morning. I'm Marianne Spanos, Director of Chautauqua County Office for the Aging in rural New York. And the ideas of population health and age-friendly health system can sometimes be very daunting for rural AAAs that are very small. What would your recommendation be how we can get started down this path of establishing an age-friendly health system? And Alexis, I want to say Carlos Sorizate.
I was going to say, I heard Spanos.
Which means
so
welcome.
One Greek to another, it's just welcome. You know, you want to take the first crack? Okay. I honestly think what resonated for me, and it can happen with rural or with anywhere, is to really understand where your connections with the health system might be, where there's an overlap, what you're able to do that's helpful for the health system. I heard you talking about data collection and understanding what data to catch. You really want to know what the health system is on the hook for, what kind of measures are they looking at? Are they looking at decreased length of stay or reducing readmissions? Or if someone comes in, I know in Philadelphia we've got some people when they're discharged and they need a particular meal plan, we've got 30 days worth of specifically designed meals to help them get the right nutrition during their recovery. There's lots of different things that you can be doing, but you do want to establish yourself with one of the local health systems that's near you and try to figure out what's important to them and how you can help them get there.
And I would agree with Alexis. I think the other thing that we all need to do better at is carry our data with us. Because we are community planners. We have to do that area plan, which, you know, sometimes it's like it's time for that dang area plan. But I think we all need to learn how to use that as our tool to not only be in compliance with our state unit on aging and the Older Americans Act, but that is our driving business plan that we need to start working on, so you're not doing all this dual business. You know, reach out to Business Acumen. I think the staff there can help, certainly at N4A. It's like that's what they're there to do, is help us be successful. But I think using the same language is critical.
That's the biggest piece. When we talk about collective impact and collaboration, what you really have to do, like use the community health needs assessment. You understand what it is as a health priority, and you start to figure out what you do that can contribute to improving that, and you work with the other stakeholders in that area, and you come up with something that you're going to hit, some target you're going to hit, and discuss what everybody's how you're going to contribute to that, and that becomes what you track and your measures for success, so that you're all tracking along the same route.
Great.
Good morning.
Thank you. Other questions?
Good morning. My name is Yashika Albert, and I'm from Valley Area Agency on Aging in Michigan. Someone spoke of having services specifically for the LGBTQ community. Can you speak on what those specific services are?
I don't have them particularly in mind. I'm not a clinician, but I know that I think people who have, for example, transitioned to another gender, there are clinical health issues that they're going to have down the road. I do not know what they are exactly, but I think some of the things are going to be different. I'm looking at you, Shireen, whether you've heard of anything yet.
You mean health services? Or
so health services and maybe some of the other complications that they may have, or differences.
Offered directly to. Right. So we do have services specifically for LGBTQ people. And really it's about bringing people together in a place where they feel safe. And we have an organization in San Francisco that provides, called Open House, that provides those services. And in addition, so people can come and experience community services together there. It's also attached to housing that's LGBTQ friendly, which is really great. And I think when they first opened the housing, I think they had over 70% of the people who actually ended up living there identified as LGBTQ, which is really hard to do with the HUD 202 funded housing. So they worked really hard to do that. I think in addition to that, that organization does a lot of training for our mainstream services, so they can go in and train other providers in how to work really well within the LGBTQ community, so that when they have people in their own organizations or meal sites, they can do a better job of being inclusive. And then we have another program that provides training for professionals and for professionals and also for families on how to work with LGBTQ people, especially focused on the dementia population. So really thinking about caregivers in LGBTQ families who have somebody with dementia in their family, and then working with the professionals who serve them to ensure that those professionals are really sensitive to working with that population. Yeah. So those are some of the things that we have.
Can I just ask you?
Sure.
Because I think you serve on the Minority Task Force for N4A, correct? And there's the implied, help me with the terminology, the implied discrimination.
Implicit bias.
Implicit bias.
Implicit, yes.
Implicit bias, yeah.
And so, I'm thinking, yesterday I heard about the discrimination in housing, and I'm guessing there's a lot of implicit discrimination, and that we, as a network, could do the best by being informed and advocating, which is a huge role.
Right.
to ensure that we are not being exclusive or that our service provider network are not being exclusive just by lack of knowledge on what we could be doing together.
You know, it's interesting, the group that I was talking about in Philly that primarily, they primarily were organized as an HIV/AIDS and serving the LGBTQ community, but they've since become a federally qualified health center, and they treat a number of underserved populations. They're treating children, they're treating duals, they're treating people with Medicaid, homeless. They're doing very comprehensive services. So it's just making sure that that's that spectrum of services that you're providing, and making sure you meet those needs.
Great, thank you. And I also wanted to reiterate that N4A has a partnership and works very closely with SAGE to really support and to learn greater ways in which to help you in servicing the LGBTQ community too. So if you have any other questions, please make sure to reach out to N4A, and we in turn will connect you with SAGE. But in saying that, do we have time probably for one more question? Do we? And all right.
I just want to add to that. I'd like to add to the LGBT thing. Howard Brown Health Center in Chicago has developed a training for nurses and for those in master's program. And I do want to reiterate, SAGE is a great resource. The biggest problem also is in people in the LGBTQ community who go into residential programs that are not specifically for LGBTQ folk, and staff training. CJE in Chicago developed a Train the Trainer program to train, it's just a DVD or CD, to provide the kinds of training for the care staff in various senior residences and nursing homes. SAGE has all of that.
Great. Absolutely, and again, we're happy to connect you with SAGE, and also we have done a webinar series on this issue as well. So, any other types of population issues that you think about on your travels home from the conference, please reach out to us, because not only do we have an incredible array of resource in your colleagues across the country, but we also have partnerships with a number of different organizations throughout the United States as well. I do think we have time for one more question. Do we have one? And I apologize, it's difficult to see you up here, but I see a hand right here.
Good morning. Nicole Cadu from the Olympia, Washington area, the Lewis Mason Thurston AAA. And thank you to the panel for your expertise and thoughts today. So my question would be, what are some emerging trends that you see related to population health that AAA's and Title VI programs need to consider?
That's a big one.
That is a big one. That is a big one.
May I just say the fact that we're considering them, okay, I think is cause for celebration, because I think that what it says is that we're in the process of truly reframing the work that we do, and we're looking for those connections we can make within that healthcare community, so that as all of us who work in this field know, many of the folks that we deal with, regardless of how we categorize them as a population, what we have are individuals who are very complex in nature, who are really struggling to navigate a very complex medical
Fragmented,
system that's difficult to understand and navigate, and trying to navigate an equally complex and difficult to understand sometimes social services system. So the fact that we are looking at categorizing these folks in a little different way and bridging over these populations into both of these sectors so that we're serving them well is exactly where I think we need to be in terms of focusing our attention, because so much of the opportunity for us to better serve and to carry out our mission is right here. I mean, we have this saying in my shop that says, maintenance is not mission.
Exactly.
mission is truly finding a better way and a more expansive way to serve the populations that we're here to serve. And I think that population health, that overlay of a population health point of view, takes us to where we want to go in terms of looking to better serve these groups of people.
You're looking at the whole, and I think honestly, Medicare, I mean, that's a huge spend, and anything you can do to make it more efficient, to serve people better, the resources are there, they're just not being spent appropriately. We'd rather spend them improving quality of life and keeping people healthy for as long as we can, rather than just throwing money away on, keeping them alive artificially and not in the best condition.
And I would also say, going back to my mudita,
Yeah, that's cool.
what we've tried to do, I'm sure we're very unique in that we have had some interesting conversations with social work departments of healthcare facilities, in that believing they do it. And what we have finally agreed to come to consensus with the largest health provider in our area is that they do a great job of planning and transitioning to the curb.
Yes.
Our expertise
That's
is
true.
taking that consumer from the curb home and getting them back for their health care provision. That brought the barriers down to now have future conversations. So I think if we can find that, where do you link best without saying we do it better than you? It's how do we do it best together, and then finding that funding mechanism for the best outcome.
Dawn, and then Howard.
Thanks, Sandy, and thanks for the question. I would just say that we need to realize that today that chronic disease is what healthcare providers that is the majority of what they will do, right? So that's just the reality of the next several decades. But I think we all have this ability as well to give voice to dementia as a chronic condition. And people with dementia are some of the most high cost, right, high risk people to serve. And we have lots of, again, answers and experience in supporting people with dementia and their family caregivers. I would also say, as I think about some emerging kinds of things, we're doing some work in Minnesota. We've been long on this path of helping to develop dementia-friendly communities. And we've worked with primary care, but we're going to do some special work now with the oral health community. I don't know how many of us work with dentists and oral health practitioners, and working on developing a concept of a dementia-friendly dental practice. And thinking about dentists as primary care, right? They're trusted in their communities. They often interact with family caregivers, but they're hungry for information about services. They'd like to know how to talk comfortably with a person about their memory loss and be really ready to make referrals and be better connected to area agencies on aging. So I think, think about this expanded group of providers. And then I would also say, I heard Kathy Greenlee when she was in Minnesota at our Gerontological Society conference, and she was framing self-neglect, older adults who self-neglect, and saying, let's really think about this as failure to thrive among older adults, and try to attract the interest of healthcare providers, again, around this relatively small, thank goodness, population, but again, a very tremendously high-risk population. That we all could do a much better job around if we had better integration across healthcare and the social supports that we provide. So again, really thinking about reframing what we already know and do best.
Great. Howard?
Well, I'm gonna use one of my old lines. It's, as they say, it's not personal, it's business. But this time it's personal. One of the things, and I've seen it here, and it's something that we as practitioners, we always say, those people, those seniors, we don't think about ourselves. Because if you live long enough, folks, guess what? You're gonna get old, all right? So as you look at providing services for our population, we also have to think about, what about ourselves? What's gonna happen to me when I get to that, or she, when we get to that particular age? Or we're gonna be able to have somebody to help us. So as you design and as you deliver these services, make it personal. Think about that person who you're looking at, who you're providing transportation, or somebody who's in the LGBT center, or somebody who lives in a rural area, that it's you. You know, as Michael Jackson used to say, the man in the mirror. It's you that you're looking at, because sooner or later, you're going to need that assistance from that area agency on aging or that local council on aging.
Unfortunately, that's all the time that we have for questions for this incredible panel. I want you to join me in thanking Alexis and your wonderful panel of colleagues. I'll let you guys go out that way. Please take what you learned today and really over the next few days back in your agencies and the communities you serve and think how you can apply it. I'd like to thank Alexis again for the passion and leadership you bring to population health, Donna, Connie, Shireen, and Howard for sharing their expertise and stories and commitment with us at this meeting. And once again, I'd like to thank our generous friends at Cigna for their support of N4A in this morning's session. So Cigna, thank you. As you just heard from the panel, there are so many opportunities for area agencies on aging and Title VI programs to play a role in population health, including around advanced illness and end-of-life care. That is why N4A joined forces with the Coalition to Transform Advanced Care, or C-TAC, earlier this year to launch a new partnership to support the Aging Network's role in caring for individuals with advanced illness. We are so pleased to have with us this morning Andrew MacPherson, Senior Policy Advisor to C-TAC, here with us today to talk about this partnership and the opportunities for the Aging Network in this space. As a Senior Policy Advisor to C-TAC and Principal at HealthSpirit, Andrew provides comprehensive strategic guidance, in-depth policy analysis, and effective messaging development on a wide range of federal health policy and political issues, including those related to quality and value-based purchasing, Medicare, Medicaid, prescription drug coverage, long-term care and supports, and chronic care management. Through his work with dozens of public and private stakeholders at the local, state, and regional and federal level, Andrew has a special emphasis on policy and political issues around the issue of advanced care and serious illness. Andrew, thanks for being with us today. It's wonderful to have you.
Well, good morning. Thank you, Sandy, for that introduction, those kind words. I'm thrilled to join you today on behalf of the Coalition to Transform Advanced Care, otherwise known as C-TAC. Based in Washington, D.C., C-TAC is a nonpartisan, not-for-profit coalition of over 140 national organizations focused squarely on improving advanced illness care for individuals and their families. From health plans to providers, organizations, consumer groups, and Fortune 50 businesses and healthcare innovators, we convene entities from all corners of the healthcare system to achieve our vision, that all Americans with advanced illness receive comprehensive, high-quality, person and family-centered care that is consistent with their goals and values and honors their dignity. So why am I here today? I'm here today to invite you to join our call to action. So without question, our healthcare system is going through extraordinary change. Health plans are looking more like providers are looking more like health plans. Payment and reimbursement is now more than ever based on value rather than volume. Not-for-profit entities are being challenged by growing interests of for-profit competitors. Consolidation is abound. And non-medical services, as you know better than anyone, are becoming more widely recognized as crucial to achieving better health and stronger communities. We believe at C-TAC that the advanced illness population, which is defined as an individual with one or more chronic conditions that have become serious enough that general health and functioning begin to decline, curative treatment loses its effectiveness, and care becomes increasingly oriented toward comfort. We believe this population plays a critical and unique role in this changing environment. Yet we have a long way to go in this country to improving advanced illness care. We've all seen the statistics, right? The 10% of the Medicare population, it was just mentioned on the last panel, 10% of the Medicare population accounts for just under 60% of the costs. Studies show that only 42%, and some even less in the senior population, 42% of individuals have even thought about their end-of-life wishes, and only 22% have actually put any sort of wish in writing in the form of an advance directive or post form. A full 90% of physicians never have brought up the issue to their patients in this country, studies have shown. And when asked where we want to die in this country, about 70% of individuals want to die at home, and yet about 70% do not. So we have a big gap to close in this country, and that's what C-TAC is focused on. We believe that closing this gap is fundamentally not just a return on investment to the government, to the healthcare system, but actually, and to our communities, but really is a return on humanity by honoring individuals' goals, values, and wishes. And we believe that you, our partners in the Aging Network, play an absolutely critical role in achieving this goal to serve these vulnerable and complex populations that are nearing the end of life. So that's why in 2018, we banded together with N4a to advocate jointly in Washington for better care for those with advanced illness and their families. And so here's what we have achieved together so far. We've determined how new models of care encourage the integration of community-based programs and resources, and how to approach health plans together to scale these innovative models of care. We've educated our respective memberships on our unique approaches and identified barriers that must be removed to achieve better, more supportive, more seamless care for this vulnerable population. And finally, we've lobbied. Oh man, have we lobbied on a bipartisan basis to make improvements to the Older Americans Act, supported by N4a, that provide better care and more support to you to serve this very unique population. We'll take a round of applause. So we have a ways to go together, but we at C-TAC and personally, I'm very proud of the work we've done together as a team. And I'd like to just close my very brief remarks today by taking a moment to read what we consider to be a critically important definition from CMS, the definition of palliative care. Palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs to facilitate patient autonomy, access to information, and choice. Suffering. By a show of hands, who here has never suffered? We've all suffered. Suffering, we believe, unites us in empathy, and higher quality palliative and advanced illness and hospice care can help. So we're honored to be working with you, Sandy and Amy and Autumn and team and the whole team at N4a, with N4a, its leadership, and most importantly, to the individuals that we, C-TAC and you, collectively serve, who are facing the most vulnerable time of their lives to improve their care, and yes, we believe to end their suffering. So for that, we thank you very much, and thanks for having me. Thank you.
It's great to work with such incredible partners. Thank you, Andrew, for C-TAC's leadership in this space and commitment to ensuring all individuals with advanced illness receive the care they need and they deserve. We are thrilled you were able to be here with us today, but we're also thrilled that we're continuing to work together with C-TAC to find increasing opportunities for our network to do more work around advanced care planning and advanced care illness care. And as we look at wrapping up this conference, I think this partnership, what Howard said in his prayer, Donna's mantra, as we all come together, I just wanted to take a few minutes to, one, thank you for being here, but also thank you for being part of the N4A family, and to give you a quick highlight on the accomplishments that we were able as an association to do this year, because you told us that these were things that were very important to you. And so before I do that, before I talk to you about what we are going to be doing, what we've done this year, I also just want to take a few minutes to also look at next year as well. And when we're looking at next year, as wonderful a time as we've had in New Orleans, right? And Howard, again, incredible thanks to you. But next year we're going to be in Portland. And to give us a taste of all that Portland has to offer, it's my pleasure to welcome Emily Farrell, Director of Senior and Disability Services with the Lane County Council of Governments of Oregon, and she's a new N4A board member, to the stage to talk to us about why you need to put this on your calendar now to be in Portland at next year's N4A conference. Emily?
Good morning. Can I just tell you, I have never been in a room with so many wonderful, caring leaders who are the most beautiful family of people. You bring with you wonderful experiences, you bring with you histories, you bring with you stories, and you share them with each other and support each other. And for this reason, I agree that this is a family, and I am so excited to invite you as my family to Portland, Oregon, so that we can share with you what it is that we have to offer. Portland was one of the first cities in the United States that was selected by the World Health Organization to start working to become an age-friendly community. Along with New York City, Portland was one of the very first age-friendly cities in the United States, which speaks miles to the work that we're doing. We also offer great access to the outdoors. Portland is conveniently located on the Columbia River, so the first thing you might notice as you're flying in is that the river is right near town. We're close to Mount Hood. We're also near the Pacific Ocean, so spending time in the fresh air is greatly encouraged and accessible. Portland has great public transportation and walkability, which is wonderful because we also have wonderful food. We're noted for our food carts and food trucks in town. We have a great craft beer and wine scene, and we have a robust local music and arts offering as well. We offer tax-free shopping and vibrant, diverse neighborhoods with distinct personalities. I and all of my Oregon and Washington colleagues want to encourage you to come to the beautiful Pacific Northwest, and just to give you a taste of how unique it is, we have this video to share with you. So when you come to Oregon, because you're all coming to Oregon, give me a call. I'll tell you my favorite restaurants and places to stop by, and we'll go out together.
So sign up now. You're going to be coming to Portland for sure for next year's conference. Hopefully you're as excited as I am about it. But before we redirect our focus to next year's conference, I just wanted to highlight some of the accomplishments that N4A has had this year. And I also wanted to highlight some of those individuals who have either retired from our family, and also a number of individuals who have passed away. We really do look at the N4A network, our area agencies on aging and Title VI colleagues as our family. So in saying that, I would like to take the opportunity to be able to thank the retirees for their service and their commitment to the network, and also appreciate the energy that they brought to their work and the invaluable contributions that they've made. And these are the individuals who have retired over the course of the past year. Many of them are colleagues that you know, and sometimes when we do this portion of the conference, what we find is some people didn't know somebody had retired. So if you see their name and you want to reach out to them, please do so. Okay. And unfortunately, this list of retirees is getting longer. So I'm also looking out on this audience, and now the lights are out. I can see you. Don't retire. Stay in the network. We need you. Thank you. I'd also like you to join me in remembering the following members of our family who have passed away over the course of the past year, and really we recognize and dedicate a moment to their spirit and their dedication to the network. I'd now like to call Deborah Stonewalls to the stage to acknowledge the great work, the incredible work of the N4A board this year.
Deborah. Sandy. Thanks, Sandy. And I do want to say that the blocking of the Portland video was on purpose. Because you can't really experience all of Portland until you go there, right, Emily? So we did that on purpose to make you wonder, what was that? You got to come and see. So that being said, I want to acknowledge all of the folks that have helped us with technology this week, with sound. It's been great, yeah? And I don't know if you know, but this little this teleprompter that's preparing Sandy and I to be able to run for office, unfortunately, my sordid past matches Howard, and I can't do it. There's too many pictures of me and Martin. You know, people would talk, so, but Sandy can. Yeah. So, but John, the man who runs this thing, he has to listen to every single word we say. He cannot daydream. He can't check his email. He can't, scroll any news. So could we give a hand to John? He's done a remarkable job. Every time we have a session, he's clued into everything we say. So thank you, John, for that. One other shout out I want to give, the Diversity Task Force was mentioned here. If you've served on that task force, could you stand and be recognized, please? Anyone here for that? Yep, we have. Thank you guys for all the work you've done in helping us infuse diversity really into everything that N4A is doing. We started a blog series in July, so watch for that, you guys. There were a lot of questions about how we can, continue to get better at reaching the diversity that is in every single one of our areas. So get involved. We have webinars. There's articles in the newsletter. There's the blog. And I know it was infused throughout the conference. Now, John, I'll go back on script. So I would like to acknowledge the great work that the board members have accomplished this year. And I would like for all of the N4A board members to please stand and be recognized. Thank you all so much for all that you do and for your service to N4A and to the entire Aging Network. I would particularly like to recognize 3 of our board members who are ending their terms and will be leaving the board. They're done right as we close this meeting. So, David Kelly, please rise and let us give you a big round of applause. There you are. Thank you, David, very much. This says, in grateful appreciation for your service on the N4A Board of Directors, 2013 to 2019. Thank you, Dave. Two of our other members who will be transitioning off the board, but not out of the network, right, Dave? The hard work continues. 2 other folks are Roy Walker and Rod Horsley. Unfortunately, we can clap. Neither Rod nor Roy were able to be with us today, but we certainly recognize all that they have contributed. So, Sandy?
You just stay here. Great. Wonderful. I want to thank N4A President Deborah Stonewalls, Deb, for her incredible leadership and commitment to N4A and for being such a great lover and doing such a great job at this conference. With her support, with the support of the board, N4A has been able to do great things this year. And again, we are your association. We've worked hard this year to achieve our mission of supporting you and our members so that you can do the great work that you do in helping older adults and people with disabilities be able to live with dignity and choice at home and in the community. Your N4A annual report is in your chair, which really highlights a lot of the work that we've been able to accomplish this year. And what you'll see when you read through that is we've done a lot. So I just wanted to take just a few quick moments just to highlight some of the things that we've done. From a policy perspective, if you move to the next slide that I'm supposed to probably be doing. Oh, you're going to do it for me. Thank you. I'm kind of tired, so I'm going to let you do all the work. We've advocated on Capitol Hill for policies that support older adults and caregivers and to maximize health, independence, and well-being. And this advocacy, I hope that you've heard throughout this conference, is really looking at not only reauthorizing the Older Americans Act, but also protecting and looking for increases in aging programs, the funding base that you just so desperately need. Our policy staff has been hard at work advocating and educating and communicating with the Hill on those important recommendations for the reauthorization of the Older Americans Act to ensure that the reauthorization proposals that are put forth really meet the needs of our members and, most importantly, of the older adults and the caregivers that you serve. We've provided AAAs and Title VI community-based organizations with the tools and the resources that you need to adapt to a changing healthcare environment through the Aging and Disability Business Institute, which hopefully throughout this conference you've gone to some of their sessions. All the while positioning our network to partner and contract with healthcare providers and payers. And we are so thrilled to continue that work with our new grants from the John A. Hartford Foundation and the SCAN Foundation for the Business Institute. So we are very excited that we get to continue this work. We've also supported the work of the Aging Network on an issue that you've heard a lot about at this conference, which is addressing social isolation and supporting the social engagement through the second year of our resource center, Engage, the National Resource Center for Engaging Older Adults, which is funded by the Administration for Community Living. I hope you all have had a chance to look at and hopefully utilize the Engage Community Toolkit, which we launched earlier this year. It's really targeted to be able to help you back home look at ways to be able to combat social isolation by including opportunities that you develop to engage older adults in your own communities. We've also promoted accessible transportation options through our leadership role in the National Aging and Disability Transportation Center, which we operate in partnership with Easter Seals. In 2018, we launched the Every Ride Counts campaign. And if you haven't gone to the website to see that, please do, because it's really targeted to promote transportation for older adults, people with disabilities in your community. And we've worked to track trends and new directions in the field of aging through N4a's capacity building project. And we'll be releasing soon a new report on innovative programs that AAAs are developing to address dementia and brain health within the communities, the issues that Don Simonson was talking about just in our last panel. This project, the capacity building project, allows us to conduct biennial surveys, and I'm making another plug for the AAA survey that we have out in the field. These are incredibly important surveys to us to allow N4a and all of you to make the case for stakeholders, policymakers about the great work that you do. So if you haven't completed that survey, please, please do. And for my Title VI friends, know your survey is coming next year. So you have a year's reprieve, but we're coming after you next. Through Dementia Friendly America, we've been leaders in cultivating the Dementia Friendly America movement across the U.S. Again, Don spoke about that, and we are thrilled to share that there are now hundreds of communities across 43 states that are involved in the Dementia Friendly America network. And the Elder Care Locator, which we operate for the Administration for Community Living, has received over 400,000 requests for assistance in 2018, and that number is exploding in 2019. What we do through the locator is when people have needs for aging services and they don't know your number, they call us, and then we transfer them to you. So we are a conduit for older adults and caregivers in need to be able to reach you. And we refer back to you and thank you for all of the great work you do on those referrals. So bottom line is, it's been an incredible year. We've published a lot of new publications, which I hope you can use and that you value to really focus in on gaining the visibility of the work that you do and also consumer-based publications, which hopefully you can use back at home to be able to highlight the services and supports that you do as well. Another way we've worked to increase the visibility of the great work that you do is through our outreach to the national media and also helping you outreach to the local media. And as many of you recall from last year's conference, we also announced that and keep building on our partnerships, including our partnership with Preferred Community Health Partners, PCHP, on a national management services organization that N4a is involved with. And also, you heard at last year's conference about our partnership with the Minority Quality Forum, and we are going to be launching an N4a index to help you do and cultivate the data that and outcome measures that you need to be able to prove your value proposition to healthcare, but also to policymakers. That will be coming soon. And we've tried to do all of this work in a very fiscally responsible way, and you'll see that in the annual report. But the bottom line is we couldn't do this work without you, our members, and we take it very, very seriously that we are your national organization. And I want to thank you for the work that you do every day to support older adults, people with disabilities, and their caregivers across the country. But before we say goodbye, I also want to thank another very special group of individuals, which is the N4a staff. And I'd ask all of the N4a staff to please rise. I truly have the privilege of being able to work with an incredible group of professionals. And there are a few of these professionals that I would particularly like to acknowledge this morning before our session closes. These are individuals who have been with the organization for many years. And I'm very proud that we have a group of professionals that are so committed to the work you do and the work that we do together, that we have longevity, not just in who we serve, but also in longevity in our staff as well. So there are 3 individuals who have been with N4a 5 years or 5 years plus. And Deborah is going to help us, our wonderful president, to acknowledge them. So when I call your name, please come to the stage. That is Autumn Campbell, our Director of Public Policy and Advocacy. Autumn, are you in the room? Here she's coming with her broken foot, so I don't want you to run really fast. Also, Jasmine Yee, who is with our Elder Care Locator. Jasmine. And also Rebecca Levine, who works so closely with membership and the board. So just keep staying on the stage. These are our 5-year and 5-year plus folks, but we have 2 people who are on the staff who have worked with N4a for 10 plus years, and they are Amy Gottwalls, Chief of Public Policy and External Affairs, and Virginia Dias, who was recognized earlier, who is our transportation guru, the co-director of the National Aging and Disability Transportation Center. And then there's one person who has been with N4a over 20 years, not quite 25, but over 20 years, longer than me. Who was very integral to this conference and also has not only become the institutional memory on the staff of N4a, but also our Energizer Bunny, and that is Martin Kleffner. To these incredible group of individuals and also to the entire N4a staff, thank you. And now, before we close this session, I have one more, both acknowledgement and there's a special reveal. So if you've stayed in this room, you may be getting a surprise. Now, before we say goodbye, I wanted to highlight one of n4a's newest preferred providers, T-Care, who has a special prize for 3 of you in the audience today. T-Care is an evidence-based, ACL-accredited, and CMS 1115 waiver-approved family caregiver support program. It's a behavioral intervention program that is scientifically proven to reduce caregiver stress and burnout by 84% in as little as 3 months and delay preventable long-term care placement on average of 21 months. We are so excited to share that T-Care is providing 3 AAAs or Title VI programs with a 1-year scholarship to the T-Care program. That means that 3 lucky agencies in this room are going to win T-Care for a year for 2 of their staff to use the T-Care system to assess and create caregiver care plans. 3 lucky people in the audience right now have a prize, but you don't know it yet. If you are a winner, please come to the front, and I'll tell you how you can find out if you're a winner. But if you are a winner, please come to the front of the room at the end of the session to meet the T-Care CEO and co-founder, Ali, and also T-Care's Director of Caregiver Services. And they will give you your special prize. Now I want everyone to look inside their annual report at your seat or at your table and see if you can find a smiley face sticker on the inside of the cover. Actually, I think there's multiple smiley face stickers. Anybody see them? I hear a yay. Do I hear a 2 yays? You're still looking. All right, 2nd yay. I'm looking for my 3rd yay. 3. All right, we've got them. So if you have one, and if you're a AAA or Title VI n4a member, then your agency is receiving the 1-year scholarship from T-Care. With that, I want to congratulate the winners and thank T-Care for that generous prize. And again, winners come to the front of the room afterwards. It's been an amazing 5 days with you all. I hope that you all have enjoyed New Orleans as much as I have. Well, probably you've enjoyed it more than I have and that's good, that's okay. But again, I want to thank Howard Rodgers, the entire New Orleans, Louisiana host committee. One more round of applause. I want to thank all of the people in the room that presented at sessions, and I want to thank all the people in the room that went to sessions. And I also can't wait to see you in Portland next year. Safe travels home. This is the end of our 44th annual conference. Thank you.